We have the pleasure of having Dr. Melvin speak to us, who works with us in primary palliative care and geriatrics. She received her undergraduate degree from Texas Southern University and her MD from Tufts in Boston, and residency and geriatrics fellowship in Baylor, one of the premier, I think, geriatrics programs in the country, and is going to come and speak with us about primary palliative care and geriatrics. Let's give her a welcome. Thank you.
Good morning, and then good afternoon to those people that are going to be on the sofa this probably weekend watching this, and hello to those others that will be watching it in between patient loads. Let's see. So what I'd like for you guys to leave with today, and I have some handouts. Some of you have the handouts already, others don't. The importance of the conversation and to incorporate what the patient's values are into the goals and the plan of care and how we approach that patient with whatever that disease process is. So we're going to look at what is primary palliative care versus secondary palliative care. What's the difference between hospice and palliative care? And then we're going to go over some just little cheat sheet tips on how to have some of those conversations. Because sometimes we think, oh, some people are natural at it, I'm going to go get them to do it. But I'm of the belief that you can fake it till you make it. And so I'm going to give you some tips so that it's going to become a lot easier to have those conversations. So what is palliative care? It looks at the care of the patient that have serious illnesses where they're going to be focused on the quality of their life and their loved one. How often do we ask a patient, where do you want to receive your care? Do you want to keep coming back and forth to the hospital? Do you want to come back and forth to the clinic? Or do you want to have your care in your home, in your assisted living, or in your nursing home? No, because why? We work within these walls. But I'm going to tell you a secret. These walls are not real. Working within the hospital system is only one aspect of that patient's care. So when you involve palliative care, what you're going to do is expand the core team. So now you have the doctor and the patient. You're going to start to include the family, and you're going to surround them with a palliative care doc. You're going to incorporate more of the nurse, social worker, and counselors. So it becomes a larger team pool. When a patient comes in to see me now, the first thing I'll ask them is, if something were to happen to them, who have they appointed as their power of attorney? Initially, a lot of people would just give their husband's name, or they would give their oldest daughter's name. And then my next question was, have you had discussions with them about what it is that's important to you? Such as, do you want to be placed on a life support machine? If something happened, do you want a feeding tube, or do you want everything short of that? And so I, on that initial visit, open up and start having the conversations, because a lot of times they don't have any answers. For my geriatric patients, I don't care how put together they are, I want to bring in a team. I want to know who their family members are, and I want to know who's going to be designated as the spokesperson. And after that first visit, I may call 3 or 4 different family members in order to achieve that. So palliative care can occur at any stage. It's nothing but an extra layer of support. There was a study done looking at patients that received palliative care versus those patients that did not receive palliative care, and those that received palliative care actually lived longer. So palliative care can be provided perinatal. So I am pregnant, I'm going to have a baby, and I know that there may be something wrong with the fetus. I can start doing palliative care there. It can be pediatric. I have just, my son, daughter's just been diagnosed with a cancer, and we're still in the phase of what treatments are we gonna do? I can start providing palliative care there. Adolescents, young adults, and then my mature adults. So primary palliative care is going to be integrating palliative care into the daily practice. And so I've already told you the first thing we do. Who's the power of attorney for health care? Just unroof it and start the discussion. That's on my first visit. It's going to look at basic pain and symptom managements. One of the things I failed to put here, but I'm going to bring it up, is the ACE score. How many of you, when you go in to see patients for the first time, you do an ACE on them? I think everybody needs to do an ACE. It's a 10-question line item that looks at the person answers the question as if they were under the age of 18 living in their parents' home. And studies have shown that patients with high ACE scores are at increased risk of cardiac disease, substance abuse, and have had trauma that may be now diagnosed as some psychiatric illness. And so what does that mean? How does that play into this? It impacts them and their care and while they're there with a certain chief complaint. Okay? You review basic discussions on goals of care. You want to integrate the patient's values into what your plan of care is. How often do we have a patient that has cancer, that needs to go on dialysis, and we're going to take into consideration what that patient's values are into the treatment? We don't. What we do is we say, you have a such and such percentage chance of living without this treatment, and you have a such and such percentage chance of living with this treatment. But we have not included into the whole realm the patient and his or her values. And then we go through the advance directive. So before the end of that first visit, I always ask, do you have an advance directive? Do you have a power of attorney for health care? Sometimes they go, yes, I do have an advance directive, and it's in the lawyer. The lawyer has it. And I said, it's going to do you a lot of good in the safe when something happens on the weekend. Who's your power of attorney? Do they know that they're your power of attorney? Have they agreed to be the power of attorney? Now, in my family, there's 2 boys and a girl. The 2 boys, one of them is my husband. And normally you would say, okay, my husband's going to be my power of attorney for health care. I love my boys, love them, but my daughter is my power of attorney for health care. Because whether she's going to do what I have asked her to do, the boys are going to negotiate. The boys are going to say, geez, we love Mom so much, can we try this one more time? My daughter's going to have the line to say, this is it. So when we have the power of attorney, I then, on my second or third visit with them, and knowing that this can occur over 6 months, I have that power of attorney come with that patient so that we can have that discussion, so they can see who I am, I can see who they are, in and when something happens. And then I always bring up the 5 wishes. You can order this. It's Aging with Dignity, and it looks at a person that I want to make decisions or healthcare decisions for me when I cannot make them for myself. And then what are my wishes? What do I want? What don't I want? What do I wish for in the case of an emergency? What do I wish for close to death? What do I wish for in a coma, not expected to wake up? What do I give permission to have happen if I have severe brain damage? My wish for how comfortable I want to be, my wish for how I want people to treat me, my wish for what I want for my loved ones. And I'll hand these out to all the patients. You can get these for nothing. Secondary palliative care is going to look at the treatment of refractory symptoms. It's going to look at conflict resolution. And it's going to address medical ineffective care. So we don't use the word futility anymore. It's medically ineffective care. So if your mom was in the hospital and someone came up to you and they told you that the care that was being provided was futile, as opposed to the care that we're providing for your mom is medically ineffective. So I'm going to just do a little sidebar. When people think about palliative care, they think, oh, let me get that consult in so I can get that DNR and I can kind of move on. That's not really what palliative care is about, okay? So I had a 93-year-old and she had community-acquired pneumonia, developed a little bit of aspiration pneumonia, and the discussion I had on her first visit was, if something were to happen to you, who do you want, who have you told that you want or don't want to happen to you in your body? And it was her son, and her son was present. And so I went on to say, have we known anybody that has been on a ventilator? Have we known anybody that have had a feeding tube? And they both shook their head yes, that they did know that. And we treated her. We did whatever we needed to do. We did a follow-up. And I don't know, 8 weeks, 3 months later, she winds up in the hospital. And the son is out playing golf. I give him a call on the golf course to say that, your mom was doing fine this morning, and there's been a turn, and she's not doing well. And what is it that she would want? And he said she would want to be intubated. And so our response, and I have to say my inner response would be, at 93 years old, why would you do that? But it was clear that that's what she wanted, because she was a Davison, and the Davisons fight, because that was in their nature. So she was intubated. She was then later had a peg tube placed. She then later had a trach. And she was then later transferred to a long-term care facility that could accommodate her, where she lived for 3 weeks. I called the son earlier this week, and I said, knowing what you know now, would you do it again? And he said yes. And he said yes because despite the fact that she had a trach and she had the feeding tube, they were still conversing with one another. They were still talking to one another. And that was something that was important to her, and that was important to him. And he told me, he said she got sick again. And we had already had the conversation that if she got sick again, that I wouldn't do anything else. And she was okay with that. So calling in palliative care doesn't always mean I'm going to get a DNR. What it's going to do is it's going to elicit what the values of that patient is and or the family that's the spokesperson. So hospice is it started off as a Medicare benefit, and the other insurances kind of jumped on board, and they go, okay, whatever Medicare says, that's how we'll reimburse. Maybe at the same rate, but I think we'll do a little bit lower rate. So the patient has to be eligible. You have to qualify for hospice. You have to have a terminal illness. You have to have a prognosis of 6 months or less, and you have to agree to forego curative therapy. Now, I don't know about you guys, but I don't know if I'm ready to forego anything. And so, hence one of the problems with the hospice program. Okay? Now, there has been some recent grants through the Center of Medicare, Medicaid Innovations, and I think this is like the third year that they have given these grants. It's through the NHPCO to hospices, where the hospice can do what's called concurrent care, where they can get aggressive treatment along with palliative care. And if I'm not mistaken, there's one hospice in this town that was granted that grant. I know because I helped write it. Aetna, Blue Cross and Blue Shield also have a concurrent component to the hospice program. A lot of this comes down to money, and although you're getting a little bit more per diem reimbursement, a person's not going to get a bone marrow with concurrent care, even though we know that that bone marrow may not take under hospice care. So it's kind of on the fringes. Here's a study, and this is through the NHPCO, and it looks at late referrals to hospice. This is data from 2016, and close to 30% of the patients were enrolled in hospice for 7 days or less. And it was published in 2017. A third of all the deaths occurred within the first week. 2/3 of the death occurred within the first month. I did a kind of a pilot study when I worked at the Hospice of Chattanooga many, many moons ago, and we pulled all patients that had died within 10 days of admission and asked families, knowing what you know now, would you elect hospice earlier? And I would have to say that 3/4 of them said, no, it was at the right time. And it was at the right time because they were able to get that treatment. That's why it's important to have conversations about what the value of the people are. Because if I'm presenting you information saying that if you don't have this treatment, this percentage of people die within that time frame, that's not the conversation I want to have. The conversation I want to have is what's important to you. And are you going to be able to meet those goals giving you those percentages? Because the decisions that they make is only as good as the information we give them. And sometimes the information we give them is skewed. Not sometimes. I don't know where that came from. I was being polite. So in palliative care, the patients are seen earlier in the disease course with a life-limiting illness. So we can see people 6 years, 8 years out. On average, we see people anywhere from 3 to 6 years before they actually start that decline. There's an improvement in the quality of life. symptom management with curative therapy. They can have that aggressive treatment and have palliative care. It's a fee-for-service, so insurances cover it. It can be provided inpatient, outpatient. There's some home-based clinic models. With hospice, it's a limit, 6 months or less. The focus is on improving the quality of the life, reducing suffering. Comfort measures are really the focus. Medicare benefit is sort of the gold key in which people try to follow. It's a bundled or a capitated reimbursement where the agency is paid a per diem per patient. So they get a flat rate per patient. It has changed in the last 3 to 4 years where patients are reimbursed at a little bit of a high, the agency is reimbursed at a higher rate on the front end. As they're into the program longer, it's at a lower rate, and then towards the end, they get a little bit more again. It was initially meant for homebound patients, but now we know that this can be provided in the nursing home, assisted living, in a bus, in the acute care setting, where you're trying to work on getting those symptoms under control in the acute care setting. So the benefits of palliative care, there's support, there's a decrease in symptoms, there's an improvement in communication, there's a focus on communication. There's an increase in survival, or maybe the same survival, people, depending upon the studies. There's a decrease, costs are the same costs. There is an increase in hope, and there is increased accessibility now to hospice within the communities. I think now, I've been doing end-of-life care and palliative care for I guess my son's 30, 29 years, and now I can say that there is a palliative care representative in every hospital. So when I first started this, I said, when we can get somebody for palliative care in the hospitals, then I would have done what I came here to achieve. But I haven't yet because I have another goal. So the impact of having hospice on symptom management is, there was a study done at University in the UK, and it looked at patients with breathlessness. And the patients with breathlessness had either lung cancer, congestive heart failure, or COPD. They were divided into the traditional arm and then the arm that received palliative care. In the palliative care arm, the patients were given, when they became short of breath, a fan, and they were given a mantra to say. And in the group, the palliative care group, they had better control or masters. They mastered their breathlessness. So they did so much better than the traditional group. The impact on communication, the American Cancer Society, in conjunction with the Center for Advanced Palliative Care, or CAPC, did a study looking at patients that had metastatic lung cancer. And this was done at the Massachusetts General Hospital in Boston. And then they looked at, the question was, are you cured of your disease? Are you cured of your disease? So they had metastatic cancer. There's a palliative care arm. There is a traditional. In the palliative care arm, 82% said no. In the non-palliative care, it was more like 59%. So it's important to do the communication. There was a HOPE study where they looked at 192 children with cancer at the Dana-Farber Hospital in Boston. And when a physician or a nurse practitioner was more upfront with the prognosis, the parents had an increase in hope because they were able to plan ahead. So they felt that high quality physician communication, being very upfront with where they were in the disease process, was important. I think it's important with our patients to hope for the best, but we always need to plan for the worst. So the studies have shown that we don't really give up hope. We may actually improve hope by having those honest conversations. So the benefit of having this discussion of goals, there's a better quality of life, you get earlier hospice referrals. It's the patient's preference. They get the care where they want the care, when they want the care. There is support for bereavement, and it has been shown to increase survival. I just mentioned this, that when we have these discussions earlier, that we don't increase depression, we don't increase hopelessness. We do not increase hopelessness. It actually gives patients hope because they can begin to plan on, and the families can plan for what's to happen next. The downside of this is the cost. You know, this isn't sexy. This isn't a new valve. This isn't a Da Vinci procedure where I can be at my computer performing something. This is wagging my tongue. And there has to be a shift in reimbursement. You know, and I think some people are really hoping that the value-based care will have some impact on this. I'm not sure about that. I think that there's a whole lot more heart people around than there are heart people around. Okay? So how do we begin to have some of these communications as clinicians? The patients make a choice based on the information that we give them. And sometimes the information that we give them is skewed. And so then they go down a rabbit hole. And then things are done more to them than for them or with them. Does that make any sense? It has to be more shared decision. And I think that we need to include the primary care physician, the family doctor, in addition to the family, the patient, and the specialty. And we need to elicit what those values are. I had this man recently, and 87, bad diabetes, hypertension, and needed to go on dialysis. He came to my office every month, and every month he said, "I hate dialysis." Every month he was tired. He was fatigued. And I said, "Well, you know, you have a choice." He goes, "No, I don't have a choice. I don't have a choice. If I stop, I'm going to die." And I said, "Look at what you can do today, and look at what you could do 6 months ago." He goes, "Well, I can't do anything." And I said, "Being dead and not doing what you want to do, help me understand what the difference might be." And he goes, "Well, I'm still here for my wife, because she still needs me." And so probably 8 weeks, 2 months before he died, he went into the hospital twice. On the third admission, I mean, it was clear to me that he was dying. You know, he was confused, he couldn't get out of bed, and it's metabolic. It's a metabolic problem. Let's fix him metabolically, and we can have him get back into dialysis. And I started having some conversations with the wife. He went home. He had dialysis on Friday. He went home, and he died before Wednesday. And so sometimes we're treating people, and we're so focused on the numbers that we don't see the person. And we don't see how that person is impacting their environment. So as a rheumatologist, I'm going to look for the rheum problem. Cardiologist, I'm going to look at the heart problem. Pulmonologist, I'm going to look for the lung problem. The oncologist, you get the picture, right? And with palliative care, we're going to take a step back, and we want to try to look at the big picture and then try to incorporate what is it that the patient wants? What are their values into the plan of care? Because sometimes the values may not be having a portacath put in and going back and forth and living my, next 12 months in and out of the hospital visiting. So I was going to come up with some, just talk about real quickly some frameworks for communication. So there's the shared decision making, there's the serious illness communication guide, and then there's Vital Talk or REMAP, and I'll try to go through REMAP in a little bit more detail. And the shared decision making is based on the patient's values and goals. You ask them what brings them joy, what are their future goals, what are their fears and worries about the future. And all of you haven't got it, but I'll give this to Mukta and some others. But this is a card, and if you don't get anything from this lecture today, not one thing, take the card. And on the card, I want you to read it. You don't have to say, oh, I'm internal medicine. These people aren't dying. My patients are healthy. I'm looking at a pediatric patient. Ask the questions. How would you like to get your medical information? What is your understanding of your situation? What's important to you? What are you hoping for? Have you thought about a time when you could be sicker? Do you have a living will or advance directive? And I've learned that when you do a history and physical and you do you see a patient, the family history component of that could take you a long time. What's a long time? I don't know, 8 years? 10 years? It's like, I don't know where you went to school, but it takes me 7 seconds. I had a sickler. She died when she was 55. I think she's one of the oldest sicklers. And she had a sister who had died at the age of 40 from microvascular stroke from her sickle cell disease. And when she turned 40, it's like she went bonkers. I couldn't figure it out. We had us a little routine. She was doing fine. And then she was in the hospital, and I just went and sat at the bedside, and we were talking. She was 39 at the time. She's going to be turning 40 in August. And this was in July. And I said, Pam, help me understand what's going on. Your numbers look good. Your electrolytes look good. You don't have any swelling. Your lungs sound good. I don't understand. And she didn't say anything on that visit. So 2 visits past that, because she's in the hospital, she says, tomorrow's my birthday. I said, well, happy birthday. She goes, I'm going to be 40. I'm like, yeah, you're still young. She goes, my sister died when she was 40. She had a stroke. I said, and you're worried that this is going to happen to you, aren't you? And she said, yes. And I said, I don't think it's going to happen. Not right now. I think you're fine. And she went from being almost near death, lights out, dark in the room, to when I went in the next time, I'm ready to go home. And then she lived another 15 years. She actually died from complications of not CNS, but cardiovascular, where she started having abnormal, malignant arrhythmias as it relates to her sickle cell. So you can do the ask, tell, ask. You want to speak less than half the time. And I'm always struck when I talk about this. I had a young guy that I asked him a question, and I thought he was catatonic. I mean, he was just sitting there. He didn't look up. He was just sitting there, and I thought, Jesus, it's Friday afternoon. I was going to make it an early evening. What am I going to do? I mean, this is me in my head talking. This is my head talk. Jesus Christ. So then I said, Terry, shut up and sit back. And I did. And it seemed like it was 15 minutes later. I'm sure it wasn't. But it's a long time later, this guy started talking. I thought, holy camole, what would I have missed? And there in his conversation, he was able to tell me about his mom. He was able to come up what was important for her, and then have us come up with a plan of care. And I could have missed it, because it could seem like a really long time. When presenting bad news, I always like to do the warning shot and then sit there and let it sink in. So if they have a biopsy, the biopsies come back positive for cancer, let them know that, and then bring families back in if a family's not with them, so that we can then come up with a plan. Because to say you have cancer and come up with a plan is too much for any one brain. They heard nothing after that was positive for cancer. And it's wasting your time, it's wasting their time, and you're going to have to go back over it again. And so I always have those visits like 15 minutes, literally 15 minutes. I don't even put them in a room. I stick them in the kitchen. Or put them in a little area where we can sit and be comfortable. So we want to look at what their goals, their wishes, what their fears and worries, their frustrations. What are they willing to trade off? You know, they don't want this, but what are they willing to trade off? How far do they want to go? And then making sure that the family is involved in the discussion. I think it's really important for our geriatric patients, our mature adults, to have family involvement. And the family that you want involved is the power of attorney. You want to have had established that. You don't want to be the dog that the tail is wagging and you've been talking to the wrong person the whole time. The person you've been talking to is a sitter that's been bringing the patient in. It's so important. Who is the power of attorney? We need to establish a power of attorney. We need to do that on the front end. So remap, we're going to reform, we're going to look at the emotions, we're going to do some map value, aligned, what those values are, and then plan. So the plan that we go into a situation with is probably not the same plan that we're going to end with. And so periodically we need to stop and relook at it. So we're in a different place. Would it be okay for us to step back a bit and talk about kind of the big picture? We expected this to go into remission after 6 months, and it looks like it's still growing. Have them name the emotion because they've been all out and invested in this, the anger, the disappointment. Explore what it means to them. Saw a lady last night at home, and she has pretty bad COPD, bad insulin-dependent diabetes, and she can't sleep. And she can't sleep because she's afraid. And she's afraid because if she lays down in the bed and she goes to sleep, she's afraid she's not going to wake up. And so people have been going in and out, in and out, in and out, but nobody's addressed that. As we think about the future, so we want to reframe it. What concerns do you have the most? Given your current situation, what's most important to you? You want to reflect on what you've actually heard. So my 93-year-old, I had to say to the son, so I'm hearing you say that you want your mom to have the trach, you want your mom to have the feeding tube, you want to give her the chance to try to come off of the vent. This is after she had failed twice. And then make a recommendation based on that shared value. I have a quick little video.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." I had a, yeah. And we do it all the time. Because you know what? Someone shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad that you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay, that didn't really come out as well as I'd like for it to have, but You got the picture? So what I want to do is leave you with some resources. So there's something called the Hospice in a Minute that you can go on and download. It's an app. You can go and look at Vital Talk, and then there's Fast Facts. So Fast Facts are the scholars in hospice and palliative medicine have reviewed the literature and can give you information on how to control symptoms, how to have certain conversations, how do you handle someone who has substance abuse that is now wanting palliative care or that is now terminally ill, because that's a whole different ball game there. And then there's a few books that I would recommend. The first one is Being Mortal. This one was one of the best-selling books, New York Times, and it was as a result of this book that we have started putting some systems in place in the hospital. So if you ever had a patient that had to have a hip replaced or some procedure on one side of the body, there's markings on there. And just like the pilots, they have to go through a checklist. Now in surgery, they go through a checklist. But then it's a little bit more than that, because we can also then extrapolate that to what we do. And so, and part of what we do is, have we done our checklist? Have we been able to establish who the power of attorney is? Have we met with the power of attorney? Have we had some discussions about what that patient's values are? The Four Things That Matter Most is by Eric Bayek. And it goes through, please forgive me, I forgive you, thank you, and I love you. When breath becomes air, it was a neurosurgeon from Stanford, had lung cancer, and it's how what he and his family experienced within and navigating the system. Rising Strong by Brene Brown, and that little cartoon was by Brene Brown, and I love her. It has really nothing to do with medicine, but it has everything to do with relationships. And part of having conversations is establishing common ground for developing relationships. But Rising Strong will not only help you as an individual, it would also impact you in your relationships with your colleagues and family members. Braving the Wilderness is also another book by Brene Brown, and it talks about the quest of belonging. Belonging is an innate desire to be part of something larger than you. It's more of a human connection. And what you will see is our patients want to be connected. They want to know that they have been heard. And sometimes they are not. They leave not feeling as if they have been heard. Why? Because we have that many patients, we got 15 minutes, I gotta look at my watch because I gotta go do rounds, blah, 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 blah. The last one is option B. It's by Sheryl Sandberg and Adam Grant. It takes a look at how we cope with death. How do we cope with death? It goes through some bereavement and grief exercises, and it goes through some data that looks at that. And, why do I bring that up to us? Why do I bring that up? Patient died. So what? I did everything I could. I'm going to move on. Because it does impact you. You just haven't dealt with it yet. And I think to acknowledge that it happened is going to be part of that. And if you don't, it piles up. And then what happens? Oh, she got burnt out. So I think it's to be that whole being present and just being aware of how things impact you. So, how do you know it's the right time for palliative care? Patient has a diagnosis of a serious illness. They're suffering despite following the directions. They have frequent either ER visits or the families call the the office, and they have multiple office visits. I did a study with Blue Cross and Blue Shield, I think it was 2012. It was a retrospective study where I went back and I was allowed to look at all of their Medicare patients, and like 6 weeks and 3 months before they died. And my speculation was that they were going to have a whole bunch of emergency room visits. It turned out that they didn't have a whole bunch of emergency room visits because they already had scheduled visits with a specialist that they were being followed by, but they had multiple primary care visits. They had a number of primary care visits. I thought that was interesting. Your caregiver is zapped of energy. There's a need for ongoing instructions about medication for symptom control. There's a need for more therapy. Thank you. Any questions?
I treat patients that are on dialysis.